possible if detection could be improved and management optimized. So basically, to explain it more simpler, uh, normal babies usually weigh about 2.5 until 3.5 kilogram, but SGA baby is much smaller than normal babies who have those weight. So basically, SGA babies will have weight less than 2.5 kilogram. Okay, next. All right, so first, we have type of SGA babies. We have symmetrical and asymmetrical. Symmetrical proportionally small all over, which by mean from head to toe, the baby is small. Whereby asymmetrical, the head is proportionately larger compared to the rest of the body, means that the body is smaller than the head. Okay, so the causes of SGA babies, they have two, classified under two, which is first genetic. Maybe the parents are small, that's why the baby are small. And chromosomal abnormality may cause them to be small. And the next one is IUGR, which is intrauterine growth restriction. Later on, I will explain what is IGR. And most babies that are born small are either constitutional small, which by mean the baby is healthy. The baby, there is no problem with the baby that caused them to be small. But the baby is small because of the genetic, such as small parents, like that. Or small because of the secondary to abnormal placenta function and have FGR. This is later on will be explained more by my friends, and I will explain later a little bit about FGR. So next, this is the features of the SGA babies. The SGA babies maybe looks full term, but also preterm baby. The preterm baby also can have SGA. So the doctor must be determine whether the baby is full term or preterm. Thin and small with little fat tissue, wrinkly skin, very red skin or plethora, breathing difficulties, lethargic due to low blood sugar. Next. Okay, so next we'll explain about IUGR. As mentioned, as I mentioned just now, IUGR is the one of the causes the baby got SGA. So IUGR is intrauterine growth retardation, which occur when a baby's growth in the womb is restricted due to shortage of oxygen and nutrients that are needed for proper growth. Such factors affecting blood flow to the baby in the womb can lead to IGR. It can classify under mother, baby, and placenta. So for the mother, such as uncontrolled blood sugar level, high blood pressure, and smoking. Okay, why smoking can affect the blood flow to the baby is because when the mother smoking, the amount of carboxyhemoglobin is higher in the maternal blood circulation than oxyhemoglobin. So that will cause lack of oxygen to the liver in the baby because there is imbalanced level of uh, oxygen in the maternal circulation. And then baby, multiple pregnancy, infection, and birth defects. So why multiple pregnancy is one of the causes because um, when the mother pregnant for the twin or more than two baby, the oxygen must be shared with all the babies so that it can cause lack of oxygen or insufficiency of oxygen. And then placenta, such as placenta abruption, placenta previa, or infection to the placenta. So as you can see in the table here, um, reduced blood flow, reduced oxygen and nutrients, poor growth of tissues and organs, and then will cause IGR. So next. Okay, so this is FGR. I will explain a little bit because after this my friend will explain more. So fetal growth restriction is a failure of a fetus to achieve its genetic growth potential. Usually will result in SGA, but some FGR will not actually be SGA because SGA and FGR are not synonym, and also as and also because as mentioned just now, SGA also can be constitutional small, which by means FGR usually because of the pathological condition that cause the baby to be small, but SGA not necessarily be pathological causes. So that's why some FGR will not actually be SGA. Okay, so group into two main categories. First, factors that directly affect the intrinsic fetal growth potential of the fetus and external influences that reduce the support of fetal growth. In the first group, which is factors that directly affect the intrinsic fetal growth potential, such as chromosome abnormalities, genetic syndrome, and fetal infections, whereby this one for the external influences, such as maternal systemic factors, maybe the mother have conditions such as cyanotic heart disease or any blood disorder. And the second one is placenta insufficiency, and and later on my friend will explain more. So I think that's it. Next. Okay, that's it from me. Thank you.
So good afternoon, doctor and my fellow friends. So today I'm going to present about the causes and the risk factor of the fetal growth restrictions. So you can see here for the causes, they can be classified into two main categories. Either there's intrinsic factor that reduce the fetal growth potential, or there is extrinsic factors that reduce the fetal growth support. So normally for the intrinsic factor, it will cause symmetrical fetal growth restrictions, while for the extrinsic factor, they will cause asymmetrical fetal growth restrictions. So we go into the first one, reduce fetal growth potential. Normally it is caused by the genetics abnormalities, and what, for example, it is aneuploidies. Aneuploidies, as we know, is the abnormal number of the chromosome in the cell. And in this case, it is particularly in the trisomy 13 and 18, which is Pantel syndrome and Edwards syndrome. And normally for the trisomy 21, which is Down syndrome, they will cause a less severe fetal growth restrictions. And other genetic abnormalities such as single gene defects and structural abnormalities will also cause the defect in developments of the organ, and thus causing to and thus leading to the fetus growth restrictions. And the last one in this category is the intrauterine infection, which include the cytomegalovirus, toxoplasmosis, uh, rubella, and even syphilis. This kind of infection will not only causing the defect in the organ development, but it will also reduce the fetal growth potential. And the next one is the reduced fetal growth support. For this category, the mechanism is almost the same, which is there is a reduce in the oxygen and nutrient supply for the baby, for the fetus, and thus causing a lack of development or influence the development of the organ as well as the tissue in the fetus. So first one is the maternal factor. For the maternal factor, one of the very major causes of uh, fetal growth restrictions is mother and undernutrition mother. It is especially this factor is very significant, especially in a like underdevelopment country, because of the poverty. They are very poor and lack of nutrition. And for the maternal hypoxia, it can be either due to underlying chronic disease such as cyanotic heart disease, or or the mother herself living at a very high altitude. That's why there is less oxygen concentration in the mother circulation. So why this can lead to fetal growth restrictions? It is because the low maternal oxygen saturation will cause less oxygen supply to the baby, to the fetus, and thus it will reduce the fetal oxygen concentration level and reduce the fetal metabolism. And the next one is the drugs. The use of drugs may also one of the causes that cause the fetal growth restrictions. For example, smoking. As mentioned by Nurain just now, smoking will increase the carboxyl hemoglobin in the maternal circulation, and it will reduce the oxygen carried by the red blood cell, and thus the oxygen supply to the fetus will be less. And for other drugs or the alcohol, it will also lead to fetal growth restrictions by several mechanisms. For example, they will affect the fetal enzyme system, they will affect the placenta blood flow, and so on. And the last one is the placenta factors. For the placenta factors, it can be subdivided into the reduced uteroplacenta perfusions or reduced fetal placenta perfusions. but both of these categories are normally just due to the placenta insufficiency. And for the reduced uterine placenta perfusions, the example include inadequate trophoblast invasion, sickle cell disease in the mother, multiple gestation, which the mother have given birth for several times, and there's reduced fetal placenta perfusion. The example is single umbilical artery, which normally should be two, and twin-to-twin perfusion syndrome. And all of these kind of condition will reduce the oxygen and nutrient supply to the babies and thus reduce the growth of tissue and organ. So why do we not need to know all these causes? It is because we need to determine what is the causes when we suspect the patient are having, if we suspect there is fetal growth restriction in the baby, even when the patient even when during pregnancy. So we need to know what is the diagnosis and then treat the underlying disease so that we can improve the outcome. So if we can treat earlier, then the outcome should be better. And next is this one is the risk factor of fetal growth restrictions. So why do we need to know the risk factor? If the pregnant woman is high risk to have fetal growth restriction, we need to monitor more carefully the size of fetus with gestational age so that we can detect earlier. So first one is the alcohol abuse. As we know, alcohol can cross the placenta and it will causing up to 500-gram reductions in the birth weight, and it will also cause other anomalies such as developmental delay in the fetus in future. So this 500-gram data is from the 10 teachers, although it might be different from Malaysia, but the actually the effect is almost the same. And then next one is the smoking. Smoking also proven to reduce up to 500-gram birth weight as compared from a smoker mother from a non-smoker mother. So if the patient is taking alcohol or smoking when she is pregnant, we need to advise them to stop. And next one is the drug addiction. For the drug addiction, it normally associated with alcohol and smoking, but heroin is proven to independently causing the low birth weight. And for the cocaine, it will also cause low birth weight and even spontaneous preterm birth. And so we need to take history carefully, whether the patient is taking any drugs or even just recreational drug, we need to take note carefully. And other chronic disease such as clotting disorder, high blood pressure, heart disease, diabetes, kidney disease, and even poor nutrition. All of these underlying disease and poor nutrition will cause less nutrition and oxygen supply from the mother to the fetus. So it will also increase the risk to develop fetal growth restrictions in the baby. And that's all from me. Thank you.
Hi, Assalamualaikum and good afternoon everyone. My name is Emmeline and today I will present about the pathophysiology and investigation. So for the pathophysiology, according to 10 teachers, they classified into two. First is symmetrical and another one is asymmetrical. For symmetrical, it is usually normally associated with factors that directly impair the fetal growth, for example, chromosomal disorders and fetal infection. For asymmetrical, which is more common, it is classically associated with uteroplacental insufficiency that leads to two things. First, reduced oxygen transfer to the fetus and impaired excretion of carbon dioxide by the placenta. Okay, next slide. Okay. Uh, okay. In uteroplacenta insufficiency, it will lead to two things. First is reduced oxygen transfer to the fetus. Next is the impaired excretion of carbon dioxide by the placenta. So this condition will lead to the fall in partial pressure of oxygen and rise in partial pressure of carbon dioxide. When this happens, the fetus will try to adapt its circulation by trying to preserve oxygen and nutrient supply to the brain. So what will happen? There will be vasodilatation in fetal brain, myocardium, and also adrenal gland. And then there will be vasoconstriction to the vital organ, for example, kidneys, splenic vessels, limbs, and subcutaneous tissues. Okay, this happen is because the fetus is trying to preserve the highly oxygenated and highly nutrient blood to the brain only. To the brain. So because of this, the liver circulation is also severely reduced. Okay, next slide will have pictures, but now I will just explain. Okay, the well oxygenated blood in the umbilical vein will pass to the right atrium through the ductus venosus. Eventually, the blood will reach the fetal brain, while the remainder going to the portal circulation in the liver. When there is fetal hypoxia, the more oxygenated blood or from the umbilical vein will be diverted through the ductus venosus, which means the liver will receive less well oxygenated blood. So in cases where chronic fetal hypoxia in FGR, it can lead to fetal acidemia of both respiratory and metabolic, which if prolonged can lead to intrauterine death if the fetus is not removed from the hostile environment. Okay, next slide. Okay. Um, Okay, so here, can you see there is a pair of umbilical arteries. The deoxygenated fetal blood will reach the placenta through the umbilical arteries. So in the placenta, what will happen is there will be gas and nutrient exchange with maternal blood. Okay, the 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 well oxygenated and highly nutrient blood will go to the umbilical vein, okay, in order to pass through the inferior vena cava. Okay, in order to go to IVC, they will have to pass a structure called ductus venosus over here. Okay, majority of the blood will flow through the ductus venosus, and the rest will go to the liver sinusoid. When there's a fetal hypoxia, what will happen is most of the blood will be diverted into ductus venosus, and the less blood will flow into the liver. Okay, this is to make sure that the brain will receive most of the blood, and these are called brain sparing effect. Okay, because of this, you can see at the picture on the right, okay, we start with asymmetrical IUGR first, where the fetal head will be bigger compared to the rest of the body. So these are called asymmetrical IUGR, and it almost happen in 70 to 80% of IUGR cases. And we can see there will be increase in HC to AC ratio, and it usually happen in chronic hypoxia and malnutrition. For symmetrical IUGR, it is usually occurs in 20 to 30% of IUGR cases, and usually it is caused by factors that directly impair the fetal growth. For example, genetic disorder and infection that cause the overall size to be smaller. Okay, next. Okay, these are actually the summary of what me and my friends has presented just now. I think you can read this by your own because you can see all those factors that can lead to the IUGR. Okay, next slide.
Okay, this one is a good slide, eh?
Okay, okay. Okay, next is the investigation and diagnosis. Okay, in order to detect cases of FGR, significant improvement can be clinical and biophysical methods. But before that, a proper history taking must be done in order to assess for the risk factors and also to screen for torch infection. Okay, next is clinical. We can do clinical palpation of uterus for the fundal height, liquor volume, and fetal mass for screening, but it is less sensitive. Symphysis fundal height measurement in centimeters closely correlates with gestational age after 24 weeks. If there's a lack of 3 centimeter or more, it might suggest growth restriction. Uh, it is a fairly sensitive parameter and serial measurement is important. Next is maternal weight gain. remain stationary or at times falling during the second half of pregnancy for mother with FGR. Okay, an extra information here. A healthy weight gain for single pregnancy women is 11 kilograms, where first trimester usually the women will gain 1 kilogram and 5 kilogram will be gained in second and third trimester. If the weight, if there's no weight gain or the mother is losing weight during the second half of pregnancy, it might indicate problem with her fetus. Okay, as the same thing goes to measurement of the abdominal girth that shows stationary or falling values. Okay, next. Okay, this is a biophysical. The first examination should confirm the clinical estimation of gestational age. Ultrasound is extremely useful not only to diagnose the growth retardation but also to identify the fetus symmetrical or asymmetrical or not. How to do it? We can use sonographic predictive values, and the most common ones are head circumference and abdominal circumference ratio and femur length. Okay, for HCAC ratio, in normally growing fetus, the HCAC ratio exceeds 1.0 before 32 weeks, and during 32 to 34 weeks, the ratio approximately 1.0. But after 34 weeks, the ratio will fall below 1.0. If the fetus is affected by asymmetrical IUGR, the head circumference remains large. What happened is the ratio also elevated. Okay, for symmetrical IUGR, both head and also abdominal circumference are reduced. So that's why the ratio remains normal. Okay, by using head circumference to abdominal circumference ratio, 85% of IUGR fetuses can be detected, and transcerebellar diameter correlates well with the gestational age. And abdominal circumference is the single most sensitive parameter to detect IUGR. Serial measurement of abdominal circumference and estimation of fetal weight are more diagnostic to fetal growth restriction. Next predictive value is the femur length. Femur length is not affected in asymmetrical IUGR. So the ratio of FLAC ratio is 22 at all gestational age from 21 weeks to term. However, if the ratio of FLAC is greater than 23.5, it might suggest that the fetus have IUGR. Okay, next slide. Okay, next is amniotic fluid volume. Okay, the reduced amniotic fluid volume is too often associated with asymmetrical IUGR. It is because there will be vasoconstriction in fetal kidney that will result in impaired urine production. Okay, so there will be impaired urine output that will cause oligohydramnios or reduced amniotic fluid. Okay, I'm not sure whether you can understand or not this, but I highly recommend you to watch in YouTube about how they do this. Okay, first, the single deepest vertical pocket SDVP of amniotic fluid less than 1 cm suggests IUGR in 96% of fetuses. Okay, look at the picture. Okay, the 4-quadrant techniques consist of measuring the vertical diameter of largest pockets of fluid in each of the 4 quadrants of the uterus. The sum of the results is the AFI, which is amniotic fluid index. And AFI between 5 and 24 centimeter is normal, and AFI less than 5, it indicates oligohydramnions. Okay, next is also anatomical survey to exclude fetal anomalies by sonography. Okay, next. Okay, next is Doppler investigation. For Doppler investigation, it is used in high-risk pregnancy. For example, the mother has hypertension, SGA or FGR, that is used in order to reduce perinatal death. And Doppler ultrasound allows the assessment of the velocity of blood within fetal and placental vessels. So the waveforms that can be obtained from the umbilical and fetal vessels and the maternal uterine artery. So the data obtained from umbilical artery provide indirect information about placenta function, while the data from the fetal vessels provide information on fetal response to hypoxia. Next. Okay, this one is umbilical artery Doppler, where the waveforms that obtained from the umbilical artery provide information on placenta resistance to blood flow. Okay, in normal pregnancy, the normal constant forward flow of blood in diastole will be seen. Okay, it is because in normal pregnancy, the blood can flow through the placenta without any difficulty. So you can have a look at the picture A, okay, where we can see this is considered as normal. Okay, in diseased placenta, the flow during the diastole may be reduced because the blood will be reflect back from the high resistant placenta that can be reduced or absent or even reversed. Okay, can you see the blue one is reduced, where we can see the difference between the peak of systole and diastole is more obvious compared to A. Okay, and the picture, the below on the right, on the left side, there's absent. And then the last picture, there will be reverse. Okay, for the reverse and diastolic flow, effectively means that during diastole, there is flow of fetal blood away from the placenta that goes back to the fetus. Okay, next. Okay, these are the uterine artery Doppler, where they will use this evaluation at 20 to 24th weeks gestation that can be used to stratify women with risk factors for SGA baby. For example, smoking, chronic hypertension, diabetes, and vascular disease, or mother that has previous SGA baby or stillbirth. So the serial ultrasound to assess fetal growth and umbilical artery Doppler for fetal well-being is recommended if the uterine artery Doppler assessment is not normal. So the Doppler ultrasound studies of the uterine arteries may demonstrate markers of increased resistance to flow during the diastolic notch. Can you see at the picture, the uterine artery notch in the waveform at early diastole? This is thought to be result from increased vascular resistance in uteroplacenta vascular bed. Okay, next. Okay, this would be the fetal vessels, where the commonly one that is measured is middle cerebral artery and ductus venosus. For the middle cerebral artery, okay, let's remember back, there's a brain sparing effect in fetus with hypoxia. So there will be cerebral vasodilation in response to it. So that's why there will be increased diastolic flow. Okay, next is a ductus venosus Doppler, which should be used for surveillance in the preterm SGA fetus with abnormal umbilical artery Doppler, and it is used to time delivery. I think that's all from me. Thank you.
Okay, Assalamu alaikum. I will proceed with the complication and management. For the complication part, I classified it in three main types, which is fetal perinatal complication, neurodevelopment complication, and maternal complication. For the first one, prenatal asphyxia is the most common complication, which is deprivation of the oxygen to a newborn infant or the fetus. The most common part is the brain, which is important for the baby to develop and will lead to cause neurodevelopment problem. I will mention it later. For hypothermia, which is decreased heat production in the baby due to decrease the fat substance and increase the surface volume ratio. Hypocalcemia, which is causes due to serum albumin and hemoglobin decrease, which is lead to albumin decrease, serum calcium will fall also down. It's also associated with the prenatal stress, asphyxia, and prematurity. hypoglycemia, which is decrease the blood glucose in the baby. Polycythemia and hyperviscosity increase the concentration of the blood and will also lead to more complication like blood cancer and clotting in the blood vessels. Thrombocytopenia and also neutropenia decrease the platelet concentration, evaluated coagulation, and decrease hyperbilirubinemia, decrease the surface deficiency, and increase meconium aspiration syndrome and respiratory stress, which is trouble in breathing, will be due to the placenta insufficiency, maternal hypertension, and preeclampsia. Sepsis and seizure and neonatal death will happen in serious complication in the prenatal and perinatal. For neurodevelopment, there is etiology and adverse event dependent. Like I mentioned before, in a fetal and perinatal, asphyxia will lead to the brain will not development, will lead to the lower intelligence in the baby, learning and behavior disorder, and neurological handicaps. Also symmetrical chromosome like genetic problem, congenital infection can lead to neurodevelopment in the baby. School performance and influenced by social classes. Next slide. For the maternal complication, there is generally does not causes harm to the mother in the healthy mother, but in the women who have underlying disease like preeclampsia, heart disease, and malnutrition can be life-threatening during the birth. Yes.
Siapa yang okay, could you turn one slide back? Okay, I would like to ask regarding the neurodevelopment, right? Because you're saying that lower intelligence, learning behavior disorder, and neurological handicaps. Why? Could you explain?
Because in the prenatal asphyxia, during the development, when there is low oxygen supply to the baby, will cause the brain will not develop as well. So during the birth, they maybe have congenital problem in the brain. So the baby will have low intelligence, learning problem disorder. That's why I understand.
Okay, any additional factor can contribute to the neurodevelopment issues in this one?
Genetic as well.
No.
No.
I think it's actually muchly contributed by the prematurity, because in the case where we deliver earlier in this baby, right? In the case of FGR, usually we were earlier delivery, right? Compared to term babies. So usually in a preterm babies, they usually have some problem with the cerebral function. So this contributing to the lower lower IQ, mental retardation.
Oh yeah.
Okay. All
Okay,
right.
thank you, doctor.
Okay, proceed then.
And risk of having another growth retard in infant in second fault. Next. For the management part, the management also I classified in 3 parts, which is early diagnosis will be a better management for the woman. For preconception management, which is apply in a woman with a pre-existing risk factor of IUGR, like lifestyle medication will be improve the nutrition, quit smoking and drinking and drug abuse. Low dose of aspirin for antiphospholipid syndrome, or and also low dose of aspirin for hereditary thrombophilias. It's the aspirin is show have decreased the risk of IUGR, the women who having risk factor. And for heparin is not effective to prevent FGR in a woman with a previous severe or the early onset of FGR. For antepartum management, the once the fetus has been identified having IUGR, the lifestyle medication also can be improved, which is stop smoking, drinking, and this thing. Close follow-up and monitoring for fetal well-being. Eventually, objective to be expedite delivery for a fetus before occurrence of compromise. But after the fetal lung maturation has been achieved, which is more than 32 weeks, we can deliver the baby who have mature lung. And in case of the severe restriction and the fetus are too mature to delivery safely, so we suggest bed rest at hospital usually to maximize the placenta blood flow and to close monitoring for the baby and the mother if need immediate delivery. Next. For delivering IUGR fetus, in case of IUGR diagnosis period to week 34 and the situation where the fetal is well and the immunity index is normal, so postpone delivery until they achieve the leg maturity of the child. Of the fetus, sorry. And in case of IUGR diagnosis at the term and the bed delivery is contemplated. For the irrespective period for gestational of IGR diagnosis with abnormal Doppler studies and with the oligohydramnios, then the fetus is delivery immediately. For the option of cesarean section is might be choice of mode of delivery for the fetus in the severe IUGR or the with or without abnormal fetal cardiography. I think that's all from me. This is our reference. Thank you. Any question?
Okay, any question from members of the floor?
Assalamualaikum doctor. I have a question. In what condition that IUGR have normal percentile and not have SGA?
Okay, macam ni. Actually, okay, to make it in brief kan. SGA is actually you consider where the baby is actually smaller rather than from the general population, right? As mentioned by the first presenter, it's a less than 10% lah. The 10% babies out of the 90% tu. So actually from the SGA, somehow we actually following the chart that is not made by the Asian. We follow the UK atau yang US punya. So from our chart tu, actually less than 10 centile tu is actually not all is the small babies. Among the 10% SGA is actually maybe it's actually normal size babies. But in that less 10% SGA babies, you actually can detect the very pathological one, which is the FGR one. So as mentioned by the next presenter, is 20% of FGR and 80% is SGA kan? Ada satu yang nampak tadi. So kalau yang FGR tu actually yang pathological. So kalau in a placenta, in a FGR baby is very significant because placenta pathological actually reduce the blood flow and oxygen to the fetal growth. So in terms of normal placenta with the baby FGR, so you have exclude, like your friend mentioned, the things that limited the growth potential of the babies, such as for the genetic aneuploidy infection, what else, sorry? Torches, right? And the rest tu is actually symmetrical IGR, and the rest of the babies is a asymmetrical GR because of the maternal and placenta factors. Your question apa tadi, adik?
Is in what condition IUGR have normal percentile?
have normal placenta.
Kan dia cakap IUGR pun boleh have normal placenta, normal growth rate. Tak semestinya ada SGA. So in what condition that happen?
Okay, kalau actually, okay, that comes actually how you diagnose FGR from the beginning. So actually there are two ways to diagnose IGR. First, you actually guna growth chart, whether it's crossing center, whether AC or estimated factor weight is crossing center. And second one is oligohydramnios in terms of baby less than 10 center. I don't see any definition that was presented dalam slide ni. Tak ada kan? Ada ke tadi sesiapa present how to diagnose IGR tadi?
Tak, rasanya tak ada.
Rasa tak nampak.
Rasanya tak ada.
You mention yang 10%, 90%, center, right? Tapi actually how you diagnose IGR is very important. From the growth chart tu, you kena plot baby parameters. Dia ada 4 column. You ada BPD, HC, you ada AC, you ada female length. And then you have the other one which is estimated fetal weight. So AC, abdominal circumference, is more sensitive in detecting of FGR. So kalau you punya growth chart, is actually growing. Growth chart you ada few center, right? Kalau you guys aware that in a growth chart tu, dia akan ada 3 line ataupun 5 line. Yang tu pun tak nampak tadi, ada ke? Dalam slide macam tak nampak lah. Ada ke antara presenter tadi yang present growth chart? Tak nampak lah. Saya ada miss. Okay, good. Okay, ni. Okay, you ada 5 line kan? Okay, you ada 5 line. Tak nampak lah berapa value. Okay, you ada 5 line which is 90, 75, 50, 25 and 10%, right? So kalau you nak kata is a SGA, bila you buat growth chart, you kena plot. You scan baby kan, you you do the details, you do the scan of fetal parameters and you plot in this graph. This graph you akan divided into AC, HC, fetal length and BPD lah. So from that, you look at the AC punya column, if dia punya growth chart tu you will plot in a few reading. You can't have 2 reading. You must have at least 3 reading. Means that 3 different visit. Let's say you have started the charting from 28 weeks and then you have subsequent scan at 34 weeks and then subsequent scan at 36 weeks. So you should see a growing chart lah bila you plot. So kalau SGA, small for gestational age, you can see that baby is actually growing below the 10 center tu, yang 10% tu. Faham? Faham ke?
Faham.
Okay. Kalau yang 10 kalau below than 10 center, you cut but growing, maksudnya dia growing along the center, maksudnya dia tak static lah, dia increasing macam tu tapi still below than 10 center, you can say this is SGA. But if let's say yang you plot tu is actually plateauing or your serial plot tu is actually crossing center. Let's say your first visit at 28 weeks tu baby at 50th centile kan dia punya AC, but subsequent scan drop to 95, subsequent scan drop at 10. So it's FGR. So in this kind of patient you still diagnose as FGR despite dia punya chart is at the other centile. And then in terms of that, you must review dia punya glycol volume. In terms of you have a crossing center, you can say this baby is FGR. Or you have SGA with AFI less than 5 pun you can say this is FGR. So macam yang soalan student tu tadi, in what kind of IGR can be diagnosed in a normal placenta, right? So it's actually you are reflecting the late insult of FGR. We have 2 types of FGR. You have early onset FGR, which is usually symmetrical FGR, or you have late onset FGR, which is usually asymmetrical FGR. Usually yang symmetrical IUGR ni yang daripada asal lagi. Contohlah dia conceive with the with the chromosome anomaly, Down syndrome. For example, Down syndrome ke Edward ke atau Patau syndrome. Usually from the beginning tu memang is very small. That baby won't achieve his growth potential. Let's say you first scan dia at 28 weeks, the AC is below 10 centi. Subsequent scan you scan pun at 34 weeks pun still below 10 centi. So you know there's something wrong with this baby. Okay, and then usually in this kind of baby, all the parameters will be same, all less than 10 centi. So you can say this is symmetrical IGR. But how are you going to diagnose asymmetrical IGR? You tengok dia punya chart bahagian HC dengan AC. Kalau let's say in an asymmetrical IGR, kepala dia besar, perut dia kecil kan. So you tengok ya bahagian HC usually, dia punya kepala tu memang growing, 50 centi, 50 centi. But in the case of AC, dia akan rendah, less than 10 centi. Okay, understand tak saya cakap laju?
Understand. Faham. Thank you, Doktor.
Okay. Okay, any more question yang ada macam confused sikit ada?
Doktor just nak tanya, IUGR dengan SGR punya term tu similar je?
Benda sama lah. Kalau you nak nampak macam canggih sikit FGR. Kalau zaman dulu IGR. But I sekarang I pakai actually kalau pakai yang IGR pun tak apa, FGR pun tak apa. But you make sure you kena kena konsisten lah, jangan kerja IGR, kerja FGR.
Doktor nak tanya lagi satu, for SGA baby they may be normal, so nak check dekat growth center ke check guna scan ke macam mana?
Okay, untuk you plot growth chart tu you kena scan babies. Kan tadi ada nampak presenter cakap there are few methods to detect SGA kan, by satu clinical estimation Fahrenheit, and then you have weight gain macam tu kan. Yang tu actually is a screening tool at the KK local clinic. Biasa misi akan check staff nurse. Staff nurse will check will measure the mother Fahrenheit every visit. So actually the first screen tool for the detection of SGA or IGR is from the KK. From KK, staff nurse measuring the Fahrenheit. If let's say less than 3 cm from the current gestational age, then she will refer to medical officer for further assessment. And then medical officer will scan the babies, will confirm the Fahrenheit and then scan the babies. If let's say the scan shows that baby is very small, then they will refer to tertiary hospital. So actually for the detection of Fahrenheit is it's like a screening one, and then you kena confirm by scan because Fahrenheit is not valid in those with thick abdomen, right? With the obese, perut labuh flabby abdomen. Baby kecil tapi perut dia tebal you dapat correspond to date ke larger than date, but actually baby is very small. So for this kind of patient, Fahrenheit is not valid. So baby must be monitored by serial scan every 4 weekly scan ke. And then the other one is a baby mother with a uterine fibroid or pelvic mass. You cannot ask the mother to be monitored by Fahrenheit in a KK because it's not reliable. Fahrenheit is not fully correspond to the gestational age with the presence of fibroid or ovarian cyst. So in this kind of patient, you also have to monitor the baby by serial scan. Then from that scan tu, that one you plot into the growth chart tu, yang ada kolom-kolom tu. And then from that growth chart tu, yang ada AC, HC, BPD, female line, then from that you boleh classify into symmetrical or symmetrical. And then once you dah plot growth chart, you actually boleh further lagi refer to tertiary hospital for exclusion of fetal anomaly. You refer to USM. USM will assess to look at the fetus. You buat detail scan, look at why in this kind of baby she has SGA atau IGR, you do the fetal anomaly scan, which actually consists of brain scan, facial morphology, cardiovascular, abdominal scan, fixed hands, and cardiac system. And then from the assessment, if baby is all normal, the findings all normal, then we can mention that grossly normal fetus. So you actually will be familiar once you enter the clinical, you will be familiar to see that SGA, IGR, detail scan, grossly normal fetus, or SGA, IGR with fetal anomaly. For example, cardiac anomaly, ASD, VSD ke, ataupun torches, video torches, positive finding of infection of maternal infection ke. So all patient with the SGIGR, kalau tertiary hospital, usually you ambil torches infection yang consist of toxo, rubella, apa lagi? CMV, yang tu kan, herpes lah. Untuk monitor dia punya intrauterine infection, which actually contribute to the fetal growth restriction in utero. And then you akan buat detail scan, and then you monitor the baby, you do Doppler to monitor the fetal and placenta circulation flow, which actually reflective the oxygen supply to the babies. Because from the Doppler itself, kalau let's say abdominal Doppler, actually buka Doppler tadi, yang 4 gambar tu. Okay, gambar nama A. The picture one is actually is a normal waveform. Doppler is normal waveform. The second one is apa ni you mention, reduce. Actually from our side, we can say that Doppler start to have absent. Number 2 tu dah turun kan, it's a reduced endoscopic flow. Number 3, the B2, B1 and B2 is the absent endoscopic flow, and the last one is a reverse. So in this case, usually the normal one, the A is the picture A is actually the normal one. The rest of the 3, you have to be careful. For the B1, you actually can observe the baby first. Let's say she presented at 34 weeks, and then you scan, and then the MO scan, Doppler showed the reduced endoscopic flow. So you actually can discharge her and see her back in 1 week time. Because Doppler normal, actually you can still try to prolong the pregnancy up to term, at least 37. But if let's say you have this subsequent, if you have the abnormal Doppler of B2 and B3, you must deliver the baby after completion of dexamethasone for the lung maturity. And if present, if ventilator available lah for the neonatal support post delivery. So in this last 2 picture, you must admit the baby, you do CTG, and you monitor the baby. And then you can plan delivery after DEXA completion and availability of ventilator. Okay. Any more question? No more question lah. Okay. And then satu lagi I nak highlight. Kalau small for gestational age, usually in our population is because of mother small lah. So most of the time SGA is actually constitutional small. Means that the mother small, the baby also small. So before you are saying that the baby is a constitutionally small, constitutional SGA, you must exclude all the pathological cause. Like I said, you do the torches infection, you do DT scan, you do CTG, like while volume is normal, then mother is small, let's say height is only 140 cm, very thin built lady. So this one you can classify as a consistent small SGA. Okay. So for the consistent SGA, you can prolong the pregnancy. You can deliver after term, which is 38, 39. But in the case of FGR, you deliver her at 36 or 37 weeks. Okay.
Doktor,
Yeah.
I want to ask for the SGA baby, boleh kalau dia adalah constitutionally small, means that they are healthy, but maybe because of the parents small, then they are small. Bila orang besar, dia orang akan achieve like size yang sama dengan ni ke, ataupun dia orang akan small?
Besar maksud you in utero or after ex utero?
I mean like bila dia orang dah makin besar lah, macam bila dia orang dah macam reach 5 years old, 6 years old macam tu.
Usually kalau in utero lah, means that in utero, usually the baby will follow the maternal genetic potential. Okay, kalau mother is a short small, baby short small, but after baby delivered, usually the baby will growing, provided with the good nutrition, and usually baby akan follow dia punya father. But in a exact, actually there are ada I baca, actually dia ada calculator, height bapa, height mak, and then you boleh tahu berapa persen dia akan dapat macam tu lah. But that one is not in the ONG lah. But actually is good why baby follow the mother, because in a mother dia kena follow baby, in a pregnancy baby have to follow the mother, because if let's say the baby is growing big for that mother, the delivery will end up with cesarean section or started labor, right? So it's a nature. Baby is actually following the mother's cavity. So bila keluar nanti depend lah, kalau let's say she actually practicing a good nutrition, overweight pun boleh dapat lah growing lah. But there actually, since you asked, I actually can add on one point to that. If you ever heard the Dohat theory, pernah dengar tak Dohat theory? DOHAD. Since Sabrina is asking about that, it's good for you guys to read about Dohat theory. So I will explain what is Dohat theory. Dohat theory is actually when the baby is a mother in your utero, it's very small. FGR with the lack of glycogen, right? So the liver will be very small because of the oxygen sparing will go to the brain, cardiac, as well as to the adrenal, right? For the survival in the utero. So so during that in the utero, there are programming. That's we call DOHAT, reprogramming of the liver, fetal liver glycogenesis. So with the maksudnya in utero dia akan try to starvation process. So in a mother in a pregnancy, baby will be starving, right? And then survive up to 37 or 36 weeks, and then will be she's being delivered. After delivery, when baby is introduced to the new diet, for example bagi makan banyak kan, so the liver reprogramming yang dalam in utero tadi akan bagi effect to the baby, which is that baby will actually have higher risk to get the metabolic syndrome. Let's say by 5 years, 10 years, 20 years, she actually will end up with having diabetic, hypertension, cholesterol and obesity because of that reprogramming in the utero tadi. So we call that the heart theory. Nanti baca Sabrina.
Oh, okay. Sure, Doctor. Thank you.
Actually, good question. Actually, I cakap masa kat postgrad je lah. Tapi dah you tanya, I cakap je lah. Okay, any more question? Ada salah lagi ke student?
Terima kasih.
Okay, kalau ada question je boleh je WhatsApp I. Suruh Syazwan share number I. Boleh je WhatsApp tanya Okay, so ada question lagi ke atau we can end here?
Rasanya dah tak ada soalan tu, Doktor.
Okay, so dah habis lah. Sorry for the changing time to time because my schedule is very full, and then now later dalam pukul 2 I ada another tutorial with a 5th year. So I think we can end here.
Okay, doktor.
Boleh.
Thank you,
Okay,
doktor.
thank you everyone.
Alright, thank you, Doctor.